This is Chapter 7 of the Pharmacology ATI Depressive Disorders. Depressive disorders are a widespread problem, ranking high among causes of disability. Clients who have major depression can require hospitalization with those observations and suicide precautions until antidepressant medications reach their peak effect. Antidepressant medications are classified into 5 main groups: selective serotonin reuptake inhibitors, or SSRIs, SNRIs, atypical antidepressants, TCAs, and MAOIs. Atypical antipsychotic medications to treat depression are used as monotherapy, an adjunct therapy for depression and bipolar depressive disorders. SSRIs, like fluoxetine. Other medications are citalopram, escitalopram, paroxetine, sertraline, and fluvoxamine. Non-SNRIs are venlafaxine, disulfenlafaxine, duloxetine, and levonorelazepam. The purpose: expected pharmacological actions. SSRIs selectively block reuptake of the monoamine transmitter serotonin in the synaptic space, thereby intensifying the effects of serotonin. SSRIs are considered first-line treatment for depression. They can take 1 to 3 weeks or longer before pharmacological benefits take effect. Therapeutic uses: major depression, OCD, bulimia, PMDD, panic disorders, PTSD, social anxiety disorder, GAD, and bipolar disorder. Complications: sexual dysfunction, anorgasmia, impotence, and decreased libido. Client education: remain aware of possible adverse effects and to notify the provider if intolerable. Utilize ways to manage sexual dysfunction, which can include lowering dosage, discontinuing medication temporarily, like a medication holiday, and using adjunct medication to improve sexual function, like sildenafil or buspirone. An atypical antidepressant, like bupropion, has fewer sexual dysfunctions and adverse effects. CNS stimulation: inability to sleep, agitation, and anxiety. Client education: notify the provider, dose might need to be lowered, take dose in the morning, avoid caffeinated beverages, and perform relaxation techniques to promote sleep. Neuroleptic malignant syndrome, nursing action: monitor client for manifestations like fever, respiratory distress, and tachycardia. Monitor client for seizure activity. Suicidal thoughts, nursing actions: observe client for suicidal tendencies, especially during early therapy. Children, adolescents, and adults 24 or under in age may be at higher risk. Monitor client for torsades de pointes. Weight loss early in therapy can be followed by weight gain with long-term treatment. Nursing actions: monitor the client's weight, encourage clients to participate in regular exercise and to follow a healthy, well-balanced diet. Serotonin syndrome can begin at 2 to 72 hours after starting treatment and can be lethal. Manifestations: confusion, agitation, poor concentration, hostility, tachycardia, low blood pressure, diaphoresis, fever, nausea, vomiting. Start symptomatic treatment: medications to create serotonin receptor blockade and muscle rigidity cooling blankets, anticonvulsants, and artificial ventilation. Client education: observe for manifestations. Withdrawal syndrome, resulting in headache, nausea, visual disturbances, anxiety, dizziness, and tremors. Manifestation begin days to weeks following the last dose and can last for 1 to 3 weeks. Client education: taper dose gradually. Hyponatremia is more likely in older adult clients taking diuretics. Nursing actions: maintain baseline blood sodium and monitor level periodically throughout treatment. Rash. Client education: a rash is treatable with an antihistamine or withdrawal of medication. Sleepiness, faintness, and lightheadedness. Client education: these adverse effects are not common but can occur. Avoid driving if these adverse effects occur. GI bleeding. Nursing actions: use caution in clients who have a history of GI bleed and ulcers, and those taking other medications that affect blood coagulation. Bruism, nursing actions: Changing to a different classification of antidepressant or adding a low-dose buspirone can decrease this effect. Contraindications and precautions. The use of SSRIs during late pregnancy can cause pulmonary hypertension of the newborn. Most are considered safe during lactation. Paroxetine increases the risk of birth defects, therefore other SSRIs are recommended. Safety is not established during lactation. SSRIs are contraindicated in clients taking MAOIs or TCAs. SSRIs need to be discontinued at least 2 weeks before initiating an MAOI. Use cautiously in clients who have liver and kidney dysfunction, cardiac disease, seizure disorders, diabetes, ulcers, and history of GI bleeding. Interactions. TCAs, MAOIs, or St. John's wort increase the risk of serotonin syndrome. Nursing actions. MAOIs should be discontinued for 14 days prior to starting an SSRI. If already taking fluoxetine and SSRI, the client should wait 5 weeks before starting an MAOI. Avoid concurrent use of TCAs and St. John's wort due to suppression of platelet aggregation that can increase the risk of GI bleed. Warfarin. Fluoxetine can displace warfarin from bound protein and result in increased risk of bleeding. Nursing actions. Monitor PT and INR levels. Assess for indications of bleeding and the need for dosage adjustment. TCAs and lithium. Fluoxetine can increase the levels of TCAs and lithium. Avoid concurrent use. NSAIDs and anticoagulants. Fluoxetine suppresses platelet aggregation and thus increases the risk of bleeding when used concurrently with NSAIDs and anticoagulants. SNRIs. This is venlafaxine. Other medications is desvenlafaxine, duoxetine, venlafaxine, and levomelanoprazole. Purpose. SNRIs block reuptake of norepinephrine as well as serotonin with effects similar to SSRIs. Therapeutic uses. Major depression, GAD, which is duoxetine, venlafaxine, desvenlafaxine, and levomelanoprazole. Social anxiety disorder, panic disorder, pain due to fibromyalgia, osteoarthritis, and low back pain. Complications: nausea, anorexia, and weight loss. Monitor weight and food intake. Headache, insomnia, anxiety. Monitor for these findings. Hypertension and tachycardia. Monitor vital signs and report changes. Neuroleptic malignant syndrome. Nursing action. Monitor client for manifestations. Monitor for seizure activity. Suicidal thoughts. Observe client for suicidal tendencies. Dizziness and blurred vision. Avoid driving and use of machinery until effects are known. Venlafaxine can cause mydriasis and can increase ocular damage if taken when the client has glaucoma. Withdrawal syndrome, resulting in headache, nausea, visual disturbances, and worsening of pretreatment manifestations. Client education, withdrawal from medication gradually. Risk for suicide in children and adolescents. Assess children and adolescents carefully for suicidal ideation and thought disorders. Sexual dysfunction. Anorgasmia, decreased libido, impotence, and menstrual changes. Client education. Report sexual dysfunction to provider. Utilize ways to manage sexual dysfunction, which can include lowering dosage, discontinuing medication temporarily, and using adjunct medications to improve sexual function, like sildenafil or buspirone. An atypical antidepressant like bupropion has fewer sexual dysfunction adverse effects. Contraindications. Avoid during the 3rd trimester due to risk of withdrawal syndrome for the newborn. Avoid if client is lactating. Precautions are needed for older clients and clients who have bipolar disorder, mania, seizure disorder, recent MI, hypertension, liver kidney impairment, or intestinal lung disease, interstitial lung disease. Taper slowly when discontinuing antidepressant medication, especially venlafaxine, which can cause severe withdrawal syndrome if stopped abruptly. Interactions. Serotonin syndrome if given concurrently with MAOIs. Stop the MAOI at least 14 days before beginning the SNRI. NSAIDs, anticoagulants, increase risk for bleeding with venlafaxine. Review the client's medications with provider, including over-the-counter medications. Alcohol and other medications affecting the CNS increase risk for CNS effects. Avoid alcohol and other CNS depressants and use caution when driving or using machinery. Kava, valerian, increases risk for CNS depression. St. John's wort can cause serotonin syndrome. Avoid these supplements. Atypical antidepressants. This is bupropion, vilazodone, mirtazapine, nifezodone, and trazodone. Expected pharmacological action. Bupropion acts by inhibiting norepinephrine and dopamine uptake and is referred to as a norepinephrine dopamine reuptake inhibitor. Therapeutic uses. Treatment for depression, major depressive disorder, and seasonal affective disorder. Alternative to SSRIs and SNRIs for clients unable to tolerate sexual dysfunction, adverse effects of these antidepressants. Aids for smoking cessation, prevention of seasonal pattern depression, and alternative treatment for choice of attention deficit disorder. Complications: headache, dry mouth, GI distress, constipation, increased heart rate, hypertension, restlessness, and insomnia. Treat headache with mild analgesic. Nausea, vomiting, anorexia, and weight loss. Monitor weight and food intake. Seizures. Avoid administering to clients at risk for seizures. This is for a client who has a head injury. Monitor for seizures and treat accordingly. Contraindications and precautions. If client is pregnant, use only if the benefit to the client outweighs the risk of the fetus. Contraindicated if client is lactating. Serious adverse reactions to nursing infants. Contraindicated in clients taking MAOIs. Contraindicated for clients who have seizure disorders or eating disorders. And used cautiously in clients who have renal and hepatic impairment. Interactions. MAOI. Phenelzine increases the risk of toxicity. MAOI should be discontinued 2 weeks prior to beginning treatment with bupropion. Other atypical antidepressants, vilazodone. These block serotonin and work as a serotonin agonist at receptor sites. First medication to work in this way. It's contraindicated with SSRIs and SNRIs and other serotonin receptor agonists. Stop MAOI at least 14 days prior to starting vilazodone. Teach manifestations of serotonin syndrome to client and instruct when to notify provider. Monitor for suicidal ideations. Many adverse effects are similar to those of SSRIs and SNRIs. Take with food to help increase absorption. Avoid grapefruit juice while taking vilazodone because grapefruit juice inhibits metabolism, resulting in an increase in this medication blood level. Mirtazapine. This is referred to as a serotonin norepinephrine disinhibitor. It increases the release of serotonin and norepinephrine by blocking presynaptic receptors and thereby increases the number of neurotransmitters available for impulse transmission. Nursing actions. Therapeutic effects can occur sooner with less sexual dysfunction than SSRIs. Mirtazapine is generally well tolerated. Clients can experience sleepiness that can be exacerbated by other CNS depressants like alcohol and benzodiazepines, weight gain, and elevated cholesterol. Take at bedtime. Report sudden onset of anxiety and agitation and panic. Nifezodone selectively inhibits the reuptake of serotonin and norepinephrine. Nursing actions. Rapidly absorbs within 1 hour when taken without food. Adverse effects are sleepiness, headache, and dizziness. Stop MAOI at least 14 days prior to starting nifezodone. Trazodone ER is a moderate selective blockade of serotonin receptors, which allows more serotonin to be available for impulse transmission. Nursing actions. Usually used with another antidepressant agent. Sedation is a potential problem, can be indicated for a client who has insomnia. Priapism is a potential adverse effect. Instruct clients to seek medical attention immediately if this occurs. Grapefruit juice inhibits metabolism, resulting in an increase in the medication blood level, resulting in toxicity. Monitor client for serotonin syndrome, agitation, tachycardia, hyperthermia, and GI symptoms. Monitor client for suicidal tendencies. TCAs, this is amitriptyline. Other medications is imipramine, doxepin, nortriptyline, amoxapine, trimipramine, desipramine, and clomipramine. These medications block reuptake of norepinephrine and serotonin in the synaptic space, thereby intensifying the effects of these neurotransmitters. It can take up to 10 to 14 days or longer before TCAs begin to work, and maximum effects might not be seen until 4 to 8 weeks. Therapeutic uses is for depression and depressive episodes of bipolar disorder. Other uses is for neuropathic pain, fibromyalgia, anxiety disorders, OCD, insomnia, ADHD, and bipolar. Complications is orthostatic hypotension. Monitor blood pressure and heart rate for clients in the hospital for orthostatic changes before administration and 1 hour after. If a significant decrease in blood pressure or increase in heart rate is noted, do not administer the medication and notify the provider. Be aware of the effects of postural hypotension, lightheadedness, and dizziness. If these occur, advise the client to sit or lie down. Orthostatic hypotension is minimized by changing position slowly. Avoid dehydration, which increases the risk of hypotension. Anticholinergic effects: dry mouth, blurred vision, photophobia, urinary hesitancy or retention, constipation, and tachycardia. Client education: minimize anticholinergic effects by chewing sugarless gum, sipping on water, wearing sunglasses, eating foods high in fiber, participating in regular exercise, increasing fluid intake, and voiding just before taking the medication. Sedation. This effect usually diminishes over time. Client education: avoid hazardous activities, take medication at bedtime. Toxicity, resulting in cholinergic blockade and cardiac toxicity evidenced by dysrhythmias, mental confusion, and agitation, followed by seizures, coma, and possibly death. Nursing actions: obtain a baseline ECG, monitor vital signs, monitor manifestations of toxicity, and notify the provider. Decrease seizure threshold. Monitor clients who have seizure disorders. Excessive sweating. Be aware of adverse effects. Perform frequent linen changes. Contraindications and precautions. If the client is pregnant, use only if the benefit to the client outweighs the risk to the fetus. Caution with lactating clients. Contraindicated in clients who have seizure disorders who have recently experienced a myocardial infarction. Use cautiously in clients who are elderly or who have coronary artery disease, diabetes, liver or kidney respiratory disorders, urinary retention or restriction, benign BPH, or hyperthyroidism. Clients at an increased risk for suicide should receive 1 week supply of medication at a time due to lethality of a toxic dose. Interactions. Concurrent use with MAOIs or St. John's wort can lead to serotonin syndrome. Concurrent use with MAOIs can cause severe hypertension. Antihistamines and other anticholinergic agents have additive anticholinergic effects. Increased effects of epinephrine, dopamine, direct-acting sympathomedics occur because uptake into the nerve terminals is blocked by TCAs, and they remain for a longer amount of time in the synaptic space. TCAs decrease the effects of ephedrine and amphetamine, inducting acting sympathomimetics, because uptake into the nerve terminals is blocked and they are unable to reach their site of action. Alcohol, benzodiazepines, opioids, and antihistamines can cause additive CNS depression when used concurrently. MAOIs, phenelzine. Other medications is isocarboxazid, trinicyclopromine, and seglaline. This is a transdermal MAOI. These medications block MAOI enzymes in the brain, thereby increasing the amount of norepinephrine, dopamine, serotonin, and tyramine available for transmission of impulses. An increased amount of these neurotransmitters at nerve endings intensify responses and relieves depression. However, the increase in tyramine can cause heightened blood pressure or hypertensive crisis if dietary and medication restrictions are not implemented. Onset of therapeutic action is not immediate and usually takes 2 to 4 weeks. less frequently used in comparison to other antidepressants due to food and drug interactions and adverse effects. Therapeutic uses: depression, bulimia, panic disorder, social anxiety, generalized anxiety, OCD, and PTSD. Complications: CNS stimulation, anxiety, agitation, mania, and hypomania. Orthostatic hypotension, hypertensive crisis, severe hypertension, headache, nausea, increased heart rate, and increased blood pressure. Hypertensive crisis resulting from intake of dietary tyramine, which could lead to cerebral vascular accident. Severe hypertension as a result of intensive vasoconstriction and stimulation of the heart, and headache and nausea and increased heart and blood pressure. Local rash with transdermal preparation. Choose a clean, dry area for each application. Apply a topical glucocorticoid on the affected area. Avoid hairy, irritated, calloused areas. Wash hands after applying new and disposing old patch. Contraindications and precautions. If the client is pregnant, use only if the benefit to the client outweighs the risk to the fetus. Safety is not established for patients who are lactating. Contraindicated in clients taking SSRIs and in those who have phenochromocystoma, heart failure, cardiovascular and cerebrovascular disease, and severe renal insufficiency. Use cautiously in clients who have diabetes and seizure disorders or those taking TCAs. Transdermal signaling is contraindicated for clients taking carbamazepine or oxcarbazepine, which can increase blood levels of the MAOI. Interactions. Indirect acting sympathomimetic medications like ephedrine and amphetamine promote the release of norepinephrine and can lead to hypertensive crisis. Use of tricyclic antidepressants can lead to hypertensive crisis. Use of SSRIs can lead to serotonin syndrome. Antihypertensive have an additive hypotensive effect. Use of meperidine can lead to hyperpyrexia. Tyramine-rich foods can lead to hypertensive crisis. Clients will most likely experience headache, nausea, increased heart rate, and increased blood pressure. Tyramine-rich foods include aged cheese, pepperoni, salami, avocados, figs, bananas, smoked fish, protein, dietary supplements, soups, soy sauce, some beers, and red wine. The MAOI transdermal patch does not seem to affect tyramine sensitivity as it's low dose, but tyramine restriction is recommended at higher doses. Concurrent use of vasopressors like phenylethylamine is caffeine can result in hypertension. Avoid foods that contain these agents like caffeinated beverages, chocolate, fava beans, and ginseng. General anesthetics. MAOIs should not be used within 10 to 14 days before or after surgery. For all medications in this chapter, nursing administration. Assist with medication regimen adherence by informing clients that it can take 1 to 3 weeks to begin experiencing therapeutic effects. Full therapeutic effects can take 2 to 3 months. Assess for suicide risk. Antidepressant medications can increase a client's risk for suicide, particularly during initial treatment. Antidepressant-induced suicide is mainly associated with clients younger than the age of 25. SSRIs and SNRIs. Avoid use of MAOIs. Obtain baseline sodium levels for older adult clients taking diuretics and monitor periodically. Atypical antidepressants. For all atypical antidepressant medications, avoid use with MAOIs. TCAs. Monitor for toxicity manifested by cardiac dysrhythmias. Administer at bedtime due to sedation and risk for orthostatic hypotension. Monitor for clients cheeking or hoarding TCAs due to potential lethality and toxicity. MAOIs. Give clients a list of tyramine-rich foods so hypertensive crisis can be avoided. Nursing evaluations of medication effectiveness. Depending on therapeutic intent, effectiveness is evidenced by the following: verbalizing improvement in mood, increased hopefulness and will to live, ability to perform ADLs, improved sleeping and eating habits, and increased interaction with peers.